Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca.
Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. The Spark theme for April is right-sizing, pandemic lessons. I'm Paula Robeson, your host for the next hour. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to the Indigenous peoples from across Turtle Island. Children's Healthcare Canada is committed to working towards forging new and deepening existing relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land as we work to measurably improve children's health outcomes from coast to coast to coast. Today, we're delighted to speak with Eyal Cohen and Astrid Gutman to bring you acute healthcare use and access among Canadian children during the pandemic. Lessons learned. I would like to briefly introduce our speakers today. Astrid Gutman and Eyal Cohen are both professors at the University of Toronto, physicians and senior scientists at SickKids, and co-directors of the Edwin S.H. Leong Center for Healthy Children. Our speakers are going to also introduce themselves. They'll go into detail of the many hats they wear during the presentation. It's now my pleasure to pass the mic to Eyal.
Thank you, Paula, and thanks all of you for joining. Good morning to most of you, and good afternoon to those in Atlantic Canada. I'm going to introduce the topic and then hand over to my colleague Astrid, and then I will conclude at the end on the topic for today's discussion: acute healthcare use and access among children during the pandemic, lessons learned. We have three learning objectives. The first one is to understand how patterns of acute healthcare use changed during the pandemic for children and youth. The second one is to explore which particular subpopulations were more or less affected in terms of their risk of needing acute care services during the pandemic, and reflect a little bit on what strategies need to be in place to support mitigating risk to children and youth during future health emergencies or pandemics. So if any of you have ever heard of John Barry's book, The Great Influenza, I highly recommend it. John Barry was a historian who wrote about the Great Influenza pandemic in the early part of the 20th century. And one thing that really struck me when I read the book was he spoke about the fact that we have very short-term memories when it comes to pandemics. And we often try to forget about them the minute that they end. And when he was speaking about the influenza pandemic in the early 20th century, he spoke about the fact that it wasn't taught in schools, the lessons learned, there are a few memorials to it. So, very, very different than other things. Like, we always learn about the Great Wars and what the historic lessons are from those, but we don't tend to spend as much time reflecting on things like pandemic. And if we look back at what happened over the last 4 years, there was a lot, and the impact of COVID on children was important, challenging, complex, And that really was an area that the two of us spent a lot of time thinking about and focusing our research on. And we wanted to share a little bit of what we learned over the course of this time for discussion and for a bit of reflection. We all know that the virus had a direct impact. In the early days, there was concern that this virus would behave, the SARS-CoV-2 virus would behave like influenza, and if anything, have a disproportionate direct impact on children. But quite early on in the pandemic, it was noted that relative to adults, the direct impact in terms of serious illness on children was smaller. On the left is a figure from some work across Canada led by Olivier Douin at St. Justine Hospital that showed, at least in the early part of the pandemic, that there were relatively few numbers of children who were admitted with acute COVID infections. That number increased over time in subsequent waves of the pandemic, but never approached anywhere what it was like in the adult health systems. And the other important direct impact was we learned of some unique effects of the SARS-CoV-2 virus on children, such as the discovery of a syndrome of multisystem inflammation that led to an important number of children getting critically ill across children's hospitals. That was an important direct effect of the virus. But most of the media and attention was on the indirect impacts of the pandemic on children. And these were things like the effects of the pandemic on the family unit, loss of family income, impacts on the effects of other family members, social distancing policies, and disruption of services. And all of those had important effects on the overall well-being of children. So I'm going to pass on to Astra to speak a little bit about why acute care is important to focus on and what the limitations of a focus on acute care are.
Thanks, Eyal. Hello, everyone. Delighted to be here. And I will, Paula mentioned we don't need to talk a lot more about our hats, but I will say that one of the hats I wear is I'm a senior scientist and chief science officer at a place called ICES. It used to be called the Institute for Clinical Evaluative Sciences, but we just go by the letters now. And this is a publicly funded not-for-profit research institute that has nodes all across Ontario, where our core funding comes from the Ministry of Health, and we bring together all of the health data that are collected in the day-to-day functioning of the healthcare system. And I'm very passionate about the use of these data, especially when they link to other data. They're an incredible platform for both research, but also surveillance, real-time improvement of the healthcare system. Part of the talk is really going to highlight how some of these data were quite useful during the pandemic in informing and being able to understand what was happening to children. I feel very strongly about trying to develop these kinds of institutes across Canada so that we can do this really in every province and potentially territory. So back to why we study acute care. So one of the things is that data from the hospital system, either from emergency department visits or from hospitalizations, are readily available. The data quality is quite high. There's very good coding practices. And these data can tell us a lot about important outcomes, certainly mortality. Not all mortality, but most deaths of children do occur in hospital. Morbidity, when children are admitted, we understand why they're admitted, but also what some of their underlying medical issues might be. And hospitalizations and emergency department visits can also reflect what's going on more widely in the healthcare system. So when children don't have good access to primary care, often they end up in the emergency department. And so it can be, these data can be used to measure the wider system. And in some ways, and sometimes, depending on what other data one might have, we can also do these kinds of analyses thinking about how they play out across different populations, either clinical populations or sociodemographic populations. At the very least, we have postal codes, so we understand what neighborhoods children go in, and then we can sometimes link to census data to understand that better. I spoke about the fact these data are readily available across Canada, which makes them very appealing in terms of doing work. But what I would like to stress, and I set this up already talking about ICS, is that the hospital level data are really enhanced when you can link to other data. So for instance, just knowing one slice of hospitalization data can be enhanced if you can actually then also understand if those same children who are hospitalized were hospitalized before. So just even linking to the hospitalization data, but then also being able to link to outpatient data, patient registries, and then more demographic data. So just as an example, in Ontario and across 3 other provinces, we've linked these data to immigration records so we can understand outcomes in the context of those who have recently come to Canada, those who might come as refugees, etc. And so this is just an infographic around ICS to show we've had data, we've been collecting data since the early 1990s, and we have a lot of data on Ontarians. And then just to show again, we're going to be concentrating on the hospital data, but we did link those data to the healthcare registry, which is essentially everyone in Ontario who's eligible for the Ontario Health Insurance Plan, so all legal residents. We also linked to other disease registries to understand how some of the COVID outcomes played out in children with chronic conditions, and linked to other data as well, which I'll describe. So then, as Eyal mentioned, so many things to think about when it came to children during the pandemic, but in particular, a lot of the work that we did was focused on some of the unintended consequences of what was happening at the level of the healthcare system, especially early in the pandemic. And this was driven, our work was really driven by some early reports from Europe around cases of delayed care, resulting in pretty important morbidity and in one case mortality of children. And those delays in care were really due to sort of 2 main issues. One was just barriers to accessing regular care. So as in Canada, there was a period of time where primary care were shut their doors and then went on to more virtual platforms. But as well, there was a huge amount. I mean, it feels like so long ago and we feel like we're kind of past it. But, if people can remember just the fear of, going to a hospital for care, going to an emergency department, worried about, catching COVID. So these were 2 really important phenomena that made us pretty concerned that we might see some of these unintended consequences. And so what we did, and I've highlighted the paper where we've summarized all of this with a fantastic big team. We essentially used Ontario population-based data that's held at ICS, where we took 3 years of data prior to the onset of the pandemic. So you can see April 2017 to March 2020. And then we essentially looked at trends and a number of different outcomes measured with hospital and emergency department data. And we modeled what those general trends were like. So there's seasonality to some of them, there's trends over time. And we developed basically a predictive model. And then what we did is we in the pandemic period, look to see what we actually observed and how that related to what we would have predicted given the baseline data. And I'll show some graphs that probably explain that better than I can. And then we really thought long and hard about what kind of measures might reflect delays in care. So one of the things we said is, if children and families are not seeking care, or having trouble seeking, getting primary care, we might see more emergency department visits where the acuity is higher because they've waited and waited, they haven't gotten early care. So we might see more urgent emergency department visits. We might see more admissions, more ICU, and potentially more deaths. We also looked at a group of outcomes and conditions that are called ambulatory care sensitive conditions. And the theory is basically these are conditions where if you seek care early on, you may not get so sick that you need to be hospitalized. So one group would be infections, so urinary tract infections, pneumonia, gastroenteritis, stomach flu. So if you seek care in the case of stomach flu, you've been advised on how to hydrate children, then you may not end up so sick that you need care in the emergency department or admission. Perforated appendix, so children will definitely have appendicitis, but if there are delays in care, you would see more of those cases of appendicitis with a perforation. And then we also were interested in studying newborn readmissions. So newborns, after discharge from a birth hospitalization, many of the early readmissions are due to feeding issues related to breastfeeding and other things that are often preventable with good access. And in particular, during the pandemic, many of you who are work in perinatal care might remember that hospitals really wanted to get the mother-baby dyads out of the hospital really quickly, again, with just concern both about bed capacity, but also contracting COVID. So newborns were discharged very, very soon and much earlier than normal. And so we were very interested in understanding whether that had any unintended consequences. We also were interested in how children who have chronic conditions fared. So were they more likely to have emergency department visits or admissions? And we looked at a number of different groups of children where we have disease registries. So everything from asthma, diabetes, inflammatory bowel disease, sickle cell anemia. And then we also did work in a group of children who are more medically complex and have very high healthcare needs, high home healthcare needs as well. So children with neurologic impairment that are also technology dependent. So things like gastrostomy tubes, and ventricular peritoneal shunts. And then the last group of outcomes, so we wondered whether or not we might see delays in children presenting for the first time with a new diagnosis. And in particular, and this was really driven by what we were hearing from Europe, new presentations of cancer and diabetes. And we also wondered whether or not when they did come to eventually come to care, whether they might be sicker. And so we had some measures of the severity of presentation. In the case of cancer, we just looked at whether or not they were more likely to need intensive care. And in the case of diabetes, whether they presented with something called diabetic ketoacidosis, which is a very, very severe issue. And we know that that's very sensitive to whether or not children are able to be seen quickly when they first start to have symptoms of diabetes. So these are very, very busy charts, but I'll just walk you through the first one on the left. So essentially, you can just see that there are lines. So the dotted lines are what we observe and what we expect from a model. So on the left are ED visits, all ED visits at the top. So in green, you can see the sort of baseline visits in green up until the pandemic hits with that dotted line, the vertical dotted line. And then you can then see the red dotted line is what we would expect just based on the previous data. And you can see the green line much, much lower. So huge drops in emergency department visits that were pretty sustained until the fall of 2021. Then again, much lower in the early part of 2022, and then higher than predicted all the way into 2022. At the bottom are the high acuity visits. So those are the ones that we thought maybe if children were deferring care would be higher, but again, much lower throughout the pandemic, all the way through the 2.5 years that we studied. The very busy graph on the right looks at all admissions on the top in red. And you can see the purple line would be what we would expect, and then much lower rates, early on, but actually quite sustained through the 2.5 years, really until the fall of 2022. So that's all admissions. The green line is what we saw for medical admissions, and then the bottom line are surgical admissions. They're much fewer in number, but those numbers were lower throughout, and that's a whole other story and an area. We know that because of reductions in the ability to do surgeries throughout the pandemic, the wait lists increased, and that's been an area that CHC has been very, Children's Healthcare Canada has been very involved with very effective advocacy for increased funding to get on top of those wait lists. I'm going to just divert for 2 slides to talk not about the work that we did, but work that was led by team members of ours, Natasha Saunders and Alen Tulani, both from SickKids, around mental health. So within that area, within those admissions, the medical admissions, embedded in those are ones that are specific to mental health. And while we saw huge decreases overall in medical admissions, this was not the case for mental health. Very early on it was, but for a number of reasons, and again, this should be the topic of an entire webinar or a full day seminar, but just to say that, as you disaggregate the data, as Alen and Natasha have done really beautifully, we saw huge increases in admissions. This is data on eating disorders by age. In red is 10 to 17-year-olds, and then green and the other colors are in adults. And you can see, massive increases in admissions for eating disorders. These data were used early on because they were analyzed in a very timely way to advocate for increased resources and beds. And then similarly, this is a paper led by Rachel Mitchell and Natasha and others on self-harm, where very important increases in youth, especially females. Those are in blue. So you can see the dotted lines is what you would expect if it was the same trend as prior to the pandemic, and you can see huge increases. So very important work around mental health. And just to make the point that what we saw writ large for medical admissions was not the case in the case of psychiatric and mental health admissions. In terms of some of our other outcomes, we saw no increase in overall all-cause mortality, either for neonates or children. We did, in fact, despite the fact that we were sending newborns home so quickly, we actually saw a decrease in newborn readmissions. This graph looks a little different than the other ones. This graph essentially is only the data from COVID, but the relative rates, or what we saw during COVID relative to what we would expect from the previous data, and anything under that dotted line of 1 means lower than expected. So overall, lower number of newborn readmissions and lower for most months. We also saw much lower than expected admissions of those transmissible ambulatory care sensitive conditions, so stomach flu, gastro, and bacterial pneumonia, until right towards the end of the study period, where we did start to see an increase in respiratory admissions, and Eyal's going to speak more to that. But in contrast, for non-transmissible ambulatory care sensitive conditions such as urinary tract infection or perforated appendix, we saw really no difference. So no signal that there was delayed care. This is an incredibly busy slide, but this is the one that reflects children with chronic conditions. And just to say that the dots in blue So again, much lower. Those are for asthma, much lower than the dotted line, meaning much lower rates of admissions in children for asthma. Again, until the spring of 2022, where we see increases in over what we would expect for asthma, and as well for children with neurologic impairment, much of which is due to respiratory conditions. Finally, I'll just talk about rates of new diabetes and cancer cases. So in this case, and unfortunately the colors are not consistent across the two, I didn't notice that when the article was in proofs, but essentially for diabetes and for cancer, we did see a drop in the first 3 months of the pandemic in new cases, about below what we would expect, and then an increase after that. Importantly, for cancer, we did not see increased severity and presentation. However, we did see a 14% overall increase in those who were presented with diabetes for the first time with diabetic ketoacidosis, including in some months, 50% higher than expected. And that was really not only during the beginning part of the pandemic, but continued across many months into the second year of the pandemic, when the healthcare system had gotten to a better sort of steady state in terms of access and primary care opening again. We did do some other work. This was led by Rachel Schulman, who's a pediatric endocrinologist here at SickKids, where we did ask the question of whether or not this increase in DKA might have had to do with the rollout of virtual care. So were children being seen virtually, and so the diagnosis was being missed. And essentially we found no difference in the percentage of children who presented in DKA who had been seen in the 4 weeks prior. But we did find overall a higher percentage of children in the COVID period had no visits previously, which made us conclude that this was more an issue of parents and families not seeking care. So just to summarize some of this work before I pass on to Eyal, just to say we did see significant and sustained decreases in hospital use, no increases in death, and very few markers, at least of what we measured, suggestive of delayed care. Definitely some great lessons learned about what we did to ensure that newborns were able to go home safely with lower lengths of stay. And certainly from what we gathered, children with chronic conditions did maintain access to the specialty care that they normally rely on for management. The exception really to the a few markers was we did see a decrease in initially of new diagnoses of cancer and diabetes, and in the case of diabetes, higher rates of DKA, which has been shown in other jurisdictions as well. Not related to more misdiagnoses, but probably delays in care seeking. Razy and others here are continuing to do surveillance on this important issue, and really speaks to the importance, if we end up in another health system disruption, about public messaging on when to seek care. So with that, and then just a few caveats. We're researchers, we always do this, but just to say, clearly some of our measures were very related to some of the other NPIs. So we saw huge decreases in many reasons for admission related probably to children not being in school, mask wearing, etc. Just because our overall rates were lower does not mean we didn't have any cases of outcomes of delayed care. But there is going to be a baseline rate of this, and we certainly didn't see differences. These outcomes, even though we're doing this at the population base, the numbers are still fairly small, so it was not possible to explore those by important markers of equity. We do lack cause-specific death data, or at least timely data, and that is an issue. And then, as I spoke about, we didn't have the capacity, because not every province have these kinds of data repositories with linked data. So it wasn't possible to do this across a number of jurisdictions. And I think as a community, we need to work to trying to, foster more of these kinds of data repositories in other provinces, so that we can do this kind of work, not just in a few provinces. All right, so I'll pass it on to Eyal.
Thanks, Astrid. So I'm just going to carry on and talk a little bit about specifically the concept of what happened in acute care related to respiratory infections. And early on in the pandemic, it was noticed in other jurisdictions, these are data from the United Kingdom, that there was a dramatic drop in respiratory infections as soon as the pandemic started and all the social distancing measures, masking, etc., closing of borders were instituted. And as a result of that, it was actually shown that childhood mortality overall actually decreased, at least at the beginning of the pandemic. And this was thought to be both the result of directly not getting these infections, and also because these infections often trigger exacerbations of other diseases. So Astrid talked a bit about asthma. Asthma is the classic example that children who are admitted to hospital with asthma are often admitted because their asthma is triggered by an infection, like a respiratory infection. So we saw these really dramatic declines early on in the pandemic of conditions like bronchiolitis and influenza, which are, really important common conditions that lead to hospitalizations. And then those who are most vulnerable are at an increased risk of severe morbidity and even mortality. And this, made some of us think, well, we need to kind of understand this kind of silver lining in a dark cloud. My particular clinical area of focus is I care for many children who have medical complexity. I'm part of a program here in my hospital that tries to provide better care for children with medical complexity who, there are many different ways of defining them, but essentially are children who need care from many different providers in many different places over time. They often have functional limitations or experience disabilities. They're often reliant on care kind of around the clock from their families, and often have kind of these characteristic complex chronic conditions. So rare genetic conditions that are multi-system, conditions that are associated with neurodevelopmental disabilities like cerebral palsy that often have multi-system manifestations associated with them. So this group of children, very, very small, about a little under 1% of Canada's children would meet some sort of criteria of children with medical complexity, but huge impact on our healthcare system. It's pre-pandemic data. It's estimated about 1 out of every $3 that we spend in child healthcare systems is dedicated to the care of these children, and a lot of that is within the acute care system. And we know for a long time that respiratory infections are a leading cause of morbidity and mortality. That's why these children are often prioritized for vaccination campaigns against things like RSV or influenza. And anything we can do to mitigate the risk of respiratory illness is really important for these children and their families. We knew early on in the pandemic that there were also the same sort of data that suggested that for this group of children, these are data from the United States, that showed that there was a reduction in hospitalization for these children, but it hadn't really been looked at specific to respiratory illnesses in any great extent. So we looked at this question of whether these changes that had been described in respiratory illnesses during the beginning of the pandemic, did they decrease more for children with medical complexity than those for children without medical complexity? And the thinking was, since they're so vulnerable to hospitalization for respiratory infections, we hypothesized that there would be a larger decrease in hospitalizations for them compared to children without medical complexity. And I want to point out this work was led by Christina Belza, who's a nurse and a researcher here at SickKids with a large project team. And the way we did this was by looking at these kind of data sets that Astrid was alluding to, but using information from the Canadian Institutes of Health Information. So CIHI has data across Canada. For this particular study, we didn't have data from Quebec, but every other province and territory in Canada had data available to look at this question. And we were able to define who children with medical complexity were using methodology that had been developed at CAI. And then they did the exact same sorts of analysis that Astrid spoke about, where we compared pre-pandemic to what happened during the pandemic and asked the question about whether, accounting for what we knew was going on pre-pandemic, whether there were differences in the outcomes compared with what was expected from modeling data from before the pandemic. So this is what we found. So these are the data on the children themselves. I just highlight a couple of points in this busy table. The first one is that, again, the numbers are very small. It's 53,000 every year across Canada, compared with over 5 million children who did not have medical complexity. So again, just about 1% of children fulfill these criteria, and that they disproportionately have these respiratory hospitalizations. So even though they're less than 1% of all kids, they're about, before the pandemic, if you look at 2017, about 8,000 children with medical complexity had respiratory hospitalizations compared with 30,000 without medical complexity. So roughly about 1 in 4 children hospitalized for respiratory illness in Canada had medical complexity. And then in 2020, 2021, when the pandemic hits, these numbers kind of go down for both groups, both those with and without medical complexity. The second point is when children with medical complexity are hospitalized, they're much more likely to have serious outcomes. So this looks at ICU and mortality during the hospitalization. And you see here that much larger numbers proportionally are hospitalized and ending up in the ICU if they have medical complexity. So on the order of a third of all hospitalizations. And this, again, is both pre and post-pandemic for children with medical complexity, whereas for children without medical complexity, ICU admissions are much less common, about 6 to 7 or 8%, depending on the year. And for mortality is uncommon in both groups. Only about 2 to 3% of all children with medical complexity hospitalized with a respiratory infectious illness die, but is almost unheard of amongst children without medical complexity. The numbers are so small we couldn't even report them while maintaining anonymity of the individuals. So again, just to reiterate that these kids, although their numbers are small, they're very, very vulnerable to these unfortunate outcomes that are associated with significant morbidity and impacts. And then when we looked at what happened during the actual pandemic, what you see here in these graphs, and these are similar to the kind of graphs that Astrid illustrated before, was that respiratory hospitalizations declined in both groups, but the relative declines were surprisingly to us larger in the non-medical complexity group. So just to walk you through this, the blue line here is what is observed data. The orange line here is the expected data. What you see is there's a little bit of seasonality associated with respiratory infections, so they tend to spike in the wintertime every year. And so you see that even before the pandemic. Then COVID-19 hits in March 2020, and you see this dramatic decline. And if you see with your eye, you can see that it's larger, and these are relative declines, the larger relative decline in children without medical complexity than those with medical complexity over the course of the pandemic. But the key point being, because children with medical complexity are at such high baseline risks to begin with, even though the relative decline was smaller in the children with medical complexity compared to those who did not have medical complexity during the pandemic, the absolute drop was quite substantial amongst children with medical complexity because they are at such higher risk. And if you kind of try to quantify what that actually means, we calculated that over the first 2 years of the pandemic, there was an overall decline in Canada, excluding Quebec, of 44,500 respiratory hospitalizations. Again, and predominantly those are non-children with medical complexity. But once you start getting to more severe outcomes, a decline of 4,200 ICU admissions across Canada, and now about half of those, or almost half of those, are children with medical complexity, and a decline of 120 in-hospital deaths from respiratory illnesses, which are virtually all in children with medical complexity. So again, this is kind of coming back to that figure I showed before of that silver lining in a dark cloud. There was, during the 2 years, there were a lot of terrible things that happened to children and families during the pandemic, but this one kind of interesting phenomenon that we actually had a demonstrable decline in an important source of morbidity and mortality related to respiratory infections. When we looked at these data by stratifying, so looking at subgrouping by sex and by age, we didn't find a consistent differences across sex between for children with and without medical complexity, but we consistently found that the older the children, the larger the declines were in terms of these respiratory illnesses, both for children with and without medical complexity. And I work on the wards quite a bit in my hospital, and this was something we saw. We saw very few young children hospitalized during those 2 years with acute respiratory infections, which are really, the bread and butter of what we see kind of on general pediatric wards in Canada. We saw a lot of mental health, and we saw a lot of other things, but in terms of respiratory illnesses in young children, which are such a common thing in acute care hospitals, there was a dramatic decline in that during the pandemic. And then one last kind of epilogue, so to speak, for this is we also looked at data of what happened in the latter stages. So as everyone probably remembers, in the fall of 2022, there was a very scary and dramatic peak in infections from not so much from COVID, but more from RSV and influenza that really caused enormous strain on acute care across the country. I picked these two newspaper articles from Alberta and British Columbia to illustrate this, and we explored then these same sorts of trends as to what happened to children with and without medical complexity in terms of acute respiratory hospitalizations. And what we found was, interestingly, remember I said that during the pandemic, there was a much, that the relative decline in acute care hospitalizations from respiratory infections was larger amongst children who didn't have medical complexity. When then the surge came back up of infections after the social distancing measures were removed and we had these large spikes of RSV and influenza, it was actually larger amongst children without medical complexity than amongst children with medical complexity. So these are data by month. This is October, this is November. 1 is what we would expect, and greater than 1 is more than what we would expect. And what we're seeing here is, the bars are further to the right for the children without medical complexity than the children with medical complexity. So putting this together with the data I showed before, essentially the largest spikes and troughs in these waves that happened by virtue of the pandemic or the release of pandemic measures were seen primarily in the non-medical complex population on a relative basis. So putting this all together, what are explanations for the findings from this study and from this series of analyses? Essentially, one could be that, so why are we not seeing as much of an effect in children with medical complexity as those without medical complexity? One could be that there are other viruses that continue to circulate during the pandemic that public health officials were surveying for that actually don't affect children without medical complexity as much as children with medical complexity. So for instance, there was still a lot of circulation of a virus called enterovirus during the pandemic. So that might explain why we didn't see as large a decline during the pandemic amongst children with medical complexity. A second explanation is that a lot of things that we call respiratory admissions related to an infection are not exactly caused by an infection. So as an example, children with medical complexity are often admitted to hospital with pneumonia, and that is sometimes because of an infection, but could be for other reasons. For instance, whether they for aspiration of food, inhalation of food. So that may be a factor that pandemic measures and pandemic factors wouldn't have had any effect on. And the third one, and I probably think this probably has as much to do with it as anything, is families who look after children with medical complexity are kind of always at a high vigilance state because they know how profoundly impactful these infections can be on their children. So these measures to prevent infections staying away from people who are sick, for instance, are probably things that families with children with medical complexity kind of do all the time. And this may also explain why that finding that I presented, why older children who we know have a baseline lower risk of being hospitalized for respiratory illnesses were also observed to have kind of a greater relative decrease during the pandemic. So, we know when a new baby is born, you don't come to the home if you're sick. So we're much more vigilant around, I think, some of these populations than others. And I think this may explain, at least in part, why we found some of these differences for children with medical complexity during the pandemic. So putting this all together in terms of what both of us have presented, it's not that straightforward a story, but I think the key lessons for us, and really looking forward to questions and comments and insights from the audience today, is overall it was primarily a good news story in terms of the effect of the pandemic on acute care use in children, with some important generalizable lessons of the importance of keeping in place these really important system level protections for disruptions to the system, and using the example that Astrid gave of the critical importance of following up newborns, the critical importance of having good surveillance systems to ensure that our patients with chronic diseases are well looked after, even when there are major disruptions to access to care in the healthcare system. And the second one is, it seems pretty clear, and I think this is reflected in statements by public health authorities nationally and internationally, that these non-pharmacologic interventions, be it masking, social distancing, improving ventilation, all those sorts of things can improve respiratory morbidity, often in profound ways. And again, I'm not going to come out here today and say that we need to do everything we did during the pandemic forever. That's obviously not sustainable and had other detrimental impacts that we know of. But certainly some of them are things to keep in mind, particularly for future waves of respiratory infections. We learned that the health system overall, in the areas that we looked at, and the key I think comment to be made is, we didn't spend a lot of time today discussing mental health, but on the whole, in terms of the medical parts of the pediatric healthcare system, capacity was more or less preserved. And lastly, reiterating a point Astrid illustrated, I think the pandemic was an incredibly insightful period to support the idea that we really need strong public health mechanisms to have population-based surveillance and the data infrastructure that's needed to identify meaningful trends. I would argue we did a really good job in acute care. We did a really good job in immunization because of a whole bunch of platforms that were put in place to track COVID immunizations. But I think that there's still a lot of work to be done to look at other immunizations and other sorts of things that we need to continue to survey to be able to identify in real time meaningful trends so that we can respond as a health system. So I will stop there and acknowledge our funders, those who provided data to us, and the many research team members and knowledge use partners who were part of the studies that the two of us presented today. And I will pass back to Paula for some Q&A.
Thank you both, Eyal and Astrid, for sharing this important evidence, kind of thought-provoking evidence, and for the valuable resources you shared. I see our audience members have some questions, so I'm going to sort those while I ask you to, Logan will launch up poll questions, ask you to respond to them. They'll help us improve over time, and you'll have to select all answers for all of the questions before submitting your response. It's my cue to get those of you who do have questions to type them in now to get them in the queue. You talked about Eyal tracking data for meaningful trends. What's your recommendation on the specific data that you might be interested in? And what's your next steps in this study or in this work?
So I'm going to pass on to Astrid because she's spent her whole career advocating for better linked data in Canada to answer that question. And then we can also address the next steps.
Yeah, thanks. It's a great question, Paula. And I would say there are two important components. So the first is the data infrastructure. And there is now, and has been for a few years, Health Data Research Network, HDRN, which is a national network that is trying to facilitate the use of the kinds of data that we described in many different provinces. These are provincial data sets. And they have to stay within provinces, and the privacy legislation and all the governance of those data really are provincial remit. So I would say the continued advocacy in provinces where those data are not easy to access from those who would use it is very important. But the second is really the capacity, like literally the people capacity to use those data. So we just don't have researchers, in every province, and the local context of the healthcare systems is really important. So I think what we need to do, and we've been trying to do this as a child health research community, is just start to, enable people who, if there are no researchers in Saskatchewan, that people from Manitoba and BC and Ontario might be able to use the Saskatchewan data, and then just trying to build collaborative networks with people so that we're able to do work, across many different provinces, and not just the ones where there's a lot of researcher capacity.
Thank you so much. As you may have heard, Children's Healthcare Canada's latest priority is around right-sizing children's health, and data has a huge role to play in that. So we may circle back, Astrid, to further pick your brains on our asks around data.
For sure.
And can I just a second piece, because you also asked what the next steps is. The other thing that both of us have kind of gotten interested in is there were things that were instituted during the pandemic that had effects on some of what we studied, that we have an opportunity now to really dive deep into these kind of data and data that are continuing to emerge over time to better understand their role in child health. So the one we have been studying in particular, and again, I want to highlight Natasha Saunders and others who have been leaders in this, David Nicholas is in Alberta and others, is this concept of virtual care, right? So we think that some of the mitigation of what could have been a disastrous effect on the child health system during the pandemic was virtual care. But virtual care has pros, it has cons, and I think we're still trying to right fit what role it has in the system. So that's another kind of example of things that were disrupted during the pandemic that I think are areas that we can continue to evaluate over time using the exact same sorts of methods that we described today and others to understand their role in a high capacity, high performing child health system.
Oh, wonderful. Thank you so much. We have a, go ahead.
Yeah.
No, go ahead.
One other point too. So, we talked about, or you saw the logo for our center, the Edwin S.H. Leong Center for Healthy Children, which is a University of Toronto and a fairly new center. We are fairly focused on health equity, and we are also very interested not just in the healthcare system, but all the other systems that are really important for children, and having a data infrastructure that reflects that is really important. So Manitoba has been a huge leader in this, so linking data across education, health, social service, justice, etc. We have an opportunity to start working on that in Ontario, and again, we feel like there are, we would like to as well develop, a network of researchers who have the ability to work with these data and do really meaningful policy work, not only in the healthcare system. So I think very exciting times.
I was chatting away on mute, pardon me. We have a new colleague here who is working, he's the managing director of Inspiring Healthy Futures, which really looks at social justice, education, other social services as part of what needs to be considered for any child to thrive. And we'll probably try and link you with him as well. There's a question. So Carrie has her hand raised. Maybe you can ask your question live, Carrie?
It looks like she just unraised her hand. Carrie, if you want to try again, we'll take your question live for you.
While Carrie is contemplating that, Brenda has asked, she said that this has been really interesting and a bit surprising, and it'll be interesting to see more data as it emerges from the last 2 years with other viral surges. She's curious about how many children with medical complexity have continued to shield or isolate themselves and have continued home learning. What impact might that have on their health?
So that's a fantastic question. Thank you for asking it. I don't have data. I only have anecdote. I have seen huge variation in terms of how families responded since the pandemic. Many families have continued to shield because they're like, oh my, for the first time we didn't have our child get extremely ill in the last few years, and this stuff works, and it does. And I have seen other families say it was an extremely difficult time for them because how socially isolated they were. And by social isolation, that includes the lack of availability of services in the community and the home. And that caused enormous stress for them, and their child being out of school and out of social settings was a limitation to their development and well-being. And I think we've seen the whole spectrum of
Right.
it.
Right.
So I don't have a clear-cut answer as to, like, I don't think there's one single response, but clearly this concept of there's what families do and what we as a society can do to help families protect their own children. So things like ventilation standards in schools, like there are things that can be done that don't put all the onus on families to make these
Right.
wicked decisions, these really, really challenging decisions that we can advocate as a child health community for.
Oh, brilliant. Most of the data you presented was from Ontario, and Astrid, you talked about the HDRN trying to sort of link up some of these data sources. Do we know if things were different in other provinces? You did, Eyal, show slides from Alberta and BC, sort of media pieces. But has anybody else done this work in other provinces, and do we know what the results are?
There's a group that's part of a larger initiative called Popcorn, that's led out of the University of Montreal, and they are accessing CIHI data on hospitalization. So they are not able to do the linkages that we can do with registries, but they are trying to do and replicate some of this work across many provinces. And I think they're trying to layer on, a bit of analysis, because we also know, how provinces responded to the pandemic, certainly in terms of school closures, and some of the other NPIs definitely differed. So they're trying to do that work. And I think that's ongoing. Nothing is published yet.
Okay, I'll keep an eye out for those.
Yeah, and just to add, so again, on the advocacy side, the data I presented was national data at CIHI, and it's an amazing organization and really enjoyed working with them. But there are limitations as to what we have available. So we have answers, but the data I presented to them, and if anyone reaches out, I'm happy to share. We have it by province. The story is pretty similar across all the provinces for what I presented on acute respiratory illnesses. The challenge is CIHI has certain data, but not other data, which are held in provinces. And we have strengths and weaknesses in terms of the data holdings in individual provinces, and strengths and weaknesses in terms of how well they're linked. And as child health advocates, where We know child health is not all about the acute healthcare system. I say that as someone who
Mhm.
works in the acute
Yep.
healthcare system. This is something we can all get behind in terms of building data assets and working with other federal partners like Statistics Canada who have data holdings themselves to ensure that we can have holistic understanding of what's happening across the country.
Would you have specific asks of folks to sort of shore up that data infrastructure? Are there specific asks you would want to make of policymakers or others?
Yeah, I mean, I would start with the healthcare data, but some of this is, as provinces do try to liberate the data, it is always, and this was the experience in Ontario, you need people who are going to focus on child health to do the work. So the data may be, as more outpatient data, for instance, comes online, you still need, there's just a lot of devil in the detail. What are the billing codes that are used? What are, for common visits that relate to children? And so you do need to have subject matter experts, I think, in every province as provinces, come online, doing, allowing more of these data linkages to occur. I know that's a bit high level, but I think,
No, that's fair.
that has to be part of the strategy. And certainly we've been trying to train people here, and Manitoba as well. And honestly, Manitoba has the best data. But they also don't, it's a smaller province, so they don't have as many researchers.
Right.
So I think there's got to be this way that we can work together where we have places where, we have good research training, and we use the data before, and then have scientists then go to, and we can do a lot virtually now as well, in terms of learning and accessing data. So it's not like people even have to move to Ontario to be able to use some of the ones here to understand and then bring that back to their province.
Oh, right.
Yeah, like some issues are really challenging. Data governance issues are complicated with federal, provincial, territorial relationships and agreements, but simple things like common data elements across provinces, common definitions of what we mean. Like I've been involved in one project with Razy Schulman, who's an endocrinologist that Astrid alluded to, where we learned that even the way different provinces are defining diabetes differ.
Oh, wow.
So something that so even those sorts of things can be challenging. So I think we're not a huge community, but I think there are certainly steps we can take that are lower hanging fruit to ensure that at least we're speaking the same languages across jurisdictions.
Oh, wonderful. Thank you so much. That's the end of our time together today. Thank you, Eyal and Astrid, for sharing your time and expertise with us. Thank you to our audience members for joining in. We know all of you are busy right now, and we hope you depart with some practical knowledge to bring back to your organization. In the weeks and months to come, we'll be hosting a few more offerings. On May 1st, tune in for Spark Live webinar enabling active play for children with medical conditions or disabilities, resources for families and clinical settings. On June 12th, we'll be hosting a webinar, Navigating EDIT-CP, Early Detection and Intervention Toolkit for Cerebral Palsy for primary care physicians, rehab specialists, and caregivers. And coming to an inbox near you, on May 6th, Children's Healthcare Canada will launch a new campaign called Beyond Band-Aids, Delivering Healthcare Fit for Kids, part of the new Right-Sizing Health Systems Serving Children and Youth priority for us. It's a culmination of 2-year focus on right-sizing children's healthcare systems, the outcomes of which is a set of tangible recommendations and calls to action for everyone involved in the child health ecosystem. And related to today's presentation, data is health data as well as social data is certainly part of that right-sizing approach. And finally, save the date for Children's Healthcare Canada's 2024 annual conference. We're heading to St. John's, Newfoundland on October 20th to 22nd. And the conference will be co-hosted by the Janeway Children's Hospital Foundation. It's great if you can watch live as your questions and comments enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our website. Thanks again for joining today. Thanks to our wonderful speakers for this presentation, and hopefully we'll see many of you back here soon. Bye, everyone.